Okay. Good evening, everybody. Uh, in the first part of the lecture, we had seen about the diagnosis, uh, rather, I would say the virology, the pathology, pathophysiology, and the diagnosis of the COVID-19 in children, along with the complications that the children have to go through or that they might face because of a COVID infection, and even what complications they can have post COVID. These were the lec- this was what we studied about in the last lecture, in the first part of this COVID-19 lecture. Now going ahead with the management of COVID in children, and the second part of the same lecture will be on prevention, how one can prevent COVID in children. So before management of the disease, we need to stage, and we need to see the stage of the disease, assess the severity of the disease, and then think of the management plan. So we can divide, for the sake of management, we can divide COVID into three parts or three types of diseases. One will be a mild or moderate type of disease where you do not require a supplementation of oxygen. We have seen that COVID affects the epithelium of the alveoli and leading to debris, collection of debris in the alveoli. And also there is an attack on the endothelial cells of the capillaries, leading to capillary leakage. And therefore, uh, because of the lung involvement, we won't the person won't be able to get adequate oxygen, and therefore we need to supply oxygen to the patient suffering from COVID. Now the requirement of oxygen to the patient of COVID is totally a subjective thing. Whether the patient needs it or no is dependent on how severe the disease is. So a severely affected person will require COVID oxygen supplement. Normal person, a mild disease person, might not require it. So the first or the most primitive stage, or uh, the least at risk stage of COVID would be the mild or moderate disease, where you do not require any additional supplementation or additional supply of oxygen. The patient is fine with a peripheral oxygen saturation at around above 90% or 92%, even at room air. The second stage of the disease will be or the second type of disease based on severity will be the severe disease, where you require to supply oxygen to the patient because the peripheral saturation of oxygen falls down. But the level does not fall down so low that you require to give a ventilatory support, whether it may be invasive or non-invasive. So the patient is able to breathe. He is not into respiratory failure, but he needs to be given oxygen. That might be an HFNO, that is the high flow nasal oxygen, or he might be requiring a simple oxygen mask. And the third stage is the critical disease, where the patient is practically on the brink of collapse, and he is onto he is nearing respiratory failure or is into respiratory failure, and then he needs a high oxygen supply, where HFNO has failed, or simple mask supplementation has failed, and he requires an invasive or a non-invasive ventilatory support. Even these patients might be not only in respiratory failure, they might be into, even though not into respiratory failure, they might be into multi-organ failure or multi-organ dysfunction syndrome. And to prevent the further uh, complication of failure, or um, failure of multiple systems, or even arrest, we need to put them on ventilatory support. Now, the general consideration of treatment include non-steroid, that every child should require a non-steroidal anti-inflammatory drug that are used chronically for other conditions, and unless and until there are specific contraindications that this person should not be administered an NSAID, one should administer NSAID to all the children. Now, what are those specific uh, contraindications for administration of NSAID? A child who is on or who is suspected to have GI bleeding, occult or frank, they should not be administered any NSAID. Or if a child is known to have a specific um, reaction, he is reactive to that specific NSAID drug, then he should not be administered any NSAID. Or if the child is having any renal disorder, a renal parenchymal disease or end stage renal disease or anything like that, or he is also on other nephrotoxic drugs, he should not be given any NSAID. The safest NSAID is a weak NSAID paracetamol, or what we call it as acetaminophen. It should be used as a symptomatic treatment for pain also, and for discomfort also, and for temperature also in children. It has been recorded to be the most or the safest and NSAID in patients of COVID. Supportive care should be provided to all pediatric patients with COVID-19. And what was the supportive care we have seen in the first part of this lecture? Supportive care includes fluid treatment, physiotherapy, that is the chest physiotherapy, mental support, and electrolyte and energy supplementation. So most of the children would improve only on supportive care. They would require no other treatment. But yes, for all patients, you need to give a supportive care. A child who is into moderate or severe COVID, or who has a associated comorbid factor, or who has got an associated lower respiratory tract infection, should be hospitalized irrespective of the stage of COVID, irrespective of the severity of COVID. There should be a precautionary hospitalization of all these children. Children with non-severe COVID may require hospital admission if they are at risk for severe disease due to underlying conditions, or if they are febrile, or they are lesser than 1 month of age. Above 1 month of age, they might not, but if they are highly febrile and less than 1 month of age, then one should hospitalize all the children. The supportive care I have spoken of, what we require is supplementation of oxygen. It might be a simple oxygen by mask, or it might at about say 6 to 8 liters or 10 liters, 4 to 10 liters, anything in between that, or it might be a high flow nasal oxygen, what we call it as HFNO, or it might be, which is equal to 6 to 10 liters, or a simple 2-liter mask oxygen by mask, or a non-invasive ventilatory support. This is basically the respiratory supportive care. If the child is in failure or has a severe lower respiratory tract infection, precautionarily the child should be taken on a ventilatory support. Does every child require it? No, every child doesn't require it. But if the child is in the at-risk group 1, or secondly, the symptoms in the child are not receding even after 1 week of the disease, that is when the cytokine storm passes away, then you need to give them a supportive respiratory care with oxygen. The second part is provision of fluids and electrolytes and energy, that is through glucose or sugars, or that might be orally or by parenteral route. And provision of empiric antibiotics as indicated for community acquired or healthcare associated pneumonia. Consider if there is a lower respiratory involvement, consider it to be an community acquired pneumonia or otherwise, and start an antibiotic empirically, even if the culture reports are awaited. So empirical management with antibiotics should include antibiotics from the cephalosporin group or the penicillin group, or higher antibiotics like the meropenem. Generally avoid antibiotics which are nephrotoxic. Talking about treatment in children, specific treatment, in the absence of adequate data on treatment in children with acute COVID-19, recommendations are based on outcome of safety data in adult patients. We didn't have that much of time to consider or to frame the COVID treatment protocols for children, and therefore all the protocols which are present at which are there followed at present, they are all based on observations in adults. The majority of children with mild or moderate COVID-19 will not progress to more severe illness and thus should be managed with supportive care alone. They don't require any other major therapy. In adults, we have used remdesivir. Basically, remdesivir was not an anti-COVID drug. It was developed for treating viral hepatitis. But in some cases, it was found that remdesivir is recommended and it reduces death and severe disease in patients with COVID-19. That is a very debatable data, because after the use of remdesivir in COVID-19, after a few months, WHO came up with a meta-analysis and said that no use of remdesivir was found. Remdesivir was neither beneficial nor harmful for any of the patient, and it did not prevent any or reduce any death in of the patient. So whether to use remdesivir or no is totally based on our own conscious. But for whom should remdesivir be used? If you are going to use it, then it is to be not used in children below 12 years of age. Only after 12 years of age one can use remdesivir, and that too not at outright that all children should receive remdesivir. Remdesivir should be used only in children about 12 years who are suspected to land up into severe disease, or who are showing a need of increase in the oxygen support. If they don't show any need of oxygen support, you need not administer remdesivir. Children aged above 16 years, but up to about 12 years to 16 years, it should be used with caution. Aged above 16 years who have an emergent or increasing need for supplemental oxygenation, regardless of whether they have risk factors or severe disease, they should be administered remdesivir. Every child above 16 years who shows a need of oxygen requirement should be given remdesivir. For 12 to 16, it is our choice, but with caution. Also, it would be beneficial if we take a pediatric infectious disease specialist to consult, if we consult him and decide whether we need to give in remdesivir or no. Usage of steroids. Dexamethasone should be used in all children with COVID-19 who require or who are on oxygen support, or who are on non-invasive ventilation or on invasive mechanical ventilation or on ECMO. If the patient has got a requirement of steroids, then in that case, one should use dexamethasone. Prednisolone, methylprednisolone, yes, they can be used, but still dexamethasone would be the drug of choice for use of for as a steroid in all patients who require respiratory support. Whether to use the monoclonal antibodies, it is not very clear. They are neither recommended, neither denied. One can use monoclonal antibodies, but it should be dependent on the risk associated with that administration. And in no case, whether the child is on ventilatory support or whether he is not, whether he is in severe disease or whether he is not, one should not use convalescent plasma for a child or for any pediatric age group patient. In any case, convalescent plasma is not to be used in children. Remember this, though it has been used and found to be partially beneficial in adults. We are going to use remdesivir. What is the dose for remdesivir? If a child is more than 3.5 kilos and lesser than 40 kgs, the dose on day 1 would be 5 mg per kg, that is the loading dose, and it is to be administered once a day. 5 mg per kg on the first day, that will be the loading dose, and from the second day on it should be 2.5 mg per kg, which we call it as the maintenance dose, for 5, 7 or 10 days. For children above 40 kilos, they should be administered the adult dose of 200 mg as loading dose on day 1 and 100 mg from day 2 to 5 or day 2 to 7 or day 2 to 10. Once a day again. How many days to use 5, 7 or 10 depends upon the severity of the disease. If the child is very severe, you can use it up to even 14 days. But you should monitor the basic functions of all the organs like the LFTs and the RFTs. Remdesivir should not be administered with hydrochloroquine. Most hydrochloroquine is basically not to be used in children less than 12 years of age. About 12 years of age, if we are going to use it, remdesivir should not be used along with hydrochloroquine, because chloroquine based co-administration may decrease remdesivir's antiviral activity. So the dose might be inadequate. Remdesivir will not act as a complete antiviral, and so chloroquine and hydrochloroquine and remdesivir should not be used together. Adverse effects of remdesivir are GI disturbances like nausea, vomiting, anorexia, and remdesivir is an hepatotoxic drug, so there will be elevation of the transaminases. ALT and AST will be increased with the use of remdesivir. We have spoken of this, that we need to give steroid support, dexamethasone support to each and every child who is hospitalized for oxygen support. If the oxygen support is being in increasing requirement, or if the child is on ventilation support, we need to give him steroids. The dose of dexamethasone should be 0.15 mg per kg orally, IV or nasogastrically once daily for 6 days. Or one can, in absence of dexamethasone, we can use prednisolone 1 mg per kg orally or nasogastric, or methylprednisolone 0.8 mg per kg intravenously once a day. Hydrocortisone can be used as an initial treatment or initial therapy because hydrocortisone is a fast-acting steroid. Dexamethasone has a moderate line of activity, whereas prednisolone and methylprednisolone, they are long-acting. Delayed onset of action and long-acting. Dexamethasone has a moderate onset of action and moderate uh, time of activity. Hydrocortisone has a quick onset of action and a short acting hydrocortisone. For neonates, dexamethasone should be used 0.5 mg per kg every 12 hourly for 7 days, followed by 0.5 mg per kg intravenously for 3 days. Neonates cannot be given dexamethasone orally. They need to, or enterally, they need to be given only by IV route. For infantile age group, we need to give the same drug at 1 to 1.5 mg per kg every 8 hourly every day for 5 to 7 days. There are no recommendations either for use or against use of monoclonal antibodies, what we have seen. It is left best to the thought of the pediatrician whether to use monoclonal antibodies or whether not to use monoclonal antibodies. And certainly we have seen that we are not going to use convalescent plasma even if the child is on ventilatory support. Immune modulators like interferon beta 1 or interleukin inhibitors like tocilizumab should not be used in children because they are very toxic. Monitoring forms the basis of treatment. Monitoring is very important and it forms the basis of treatment, the basic part of treatment. Half of the treatment includes monitoring. Now, what parameters should we look for in monitoring? This monitoring will be helpful in early detection of deterioration of the patient and improvement also. So what parameters we are going to see in children? Whether there is respiratory distress, distress is increasing, whether there is dyspnea, and how do we identify dyspnea in children? For infants, it would be grunting, it would be central cyanosis, or inability to breastfeed. These are the signs of respiratory distress in infants. Whether there is central cyanosis like blue lips or blue face, whether there is chest pain or pressure the patient says of that, whether there are any signs associated with shock like cold clammy skin, mottled skin, confusion, delirium, difficulty in arousing, reduced urine output. All these signs, they are indicative of impending shock. So fall in blood pressure specific for that age group. So one should think of, or one should monitor all these signs which are important and should think of them. A rise in the sign of in these signs is indicative of impending shock, and so one should immediately manage these symptoms with care at an early time without losing time. The another sign whether the child is deteriorating or no is seen in adult or a bit grown up children, where the child is able to feed or no, or drink any liquids or no, or he is unable to drink even liquids. If it is so, that shows that the child is deteriorating. So these were the guidelines about managing COVID in children. Yes, apart from this, we need to use chest physiotherapy as one part of treatment. Now, the child has been treated for COVID-19. He has grown up, he has recovered from that, and then he has landed up later on into the complication of MISC. The treatment for MISC is practically the same as that of COVID-19. Similarly, like COVID-19, for a patient with MISC, one should not use tocilizumab in any case, even if the child is in MISC. Intravenous immunoglobulin and corticosteroids are generally used as the first line treatment along with NSAIDs like paracetamol, which is a very safe NSAID. Interleukin 1 antagonist can be used in refractory cases. Immunomodulatory treatment, should that be used or no, is totally left to the pediatrician because no safety data and no efficacy data are available. So this was about managing MISC. How about prevention about COVID? There are 3 vaccines which have been approved by FDA to be used, FDA USA, to be used as COVID vaccines. 2 of them, they are mRNA vaccines manufactured and marketed by Pfizer and Moderna, whereas third one is a a vector vaccine manufactured by Johnson and Johnson. Later on, it was found that Johnson and Johnson vaccine had a lot of problems over there. It came up with a few complications, and therefore Johnson and Johnson vaccine was withdrawn. It was claimed that the mRNA vaccines are safe and they have a long lasting immunity, but that has also been found to be a tall claim. mRNA vaccines do not confer any better immunity as compared to the conventional vaccine. Rather, mRNA vaccines have shown to have many many adverse reactions, which are now noted with the EU FDA or the US FDA. These vaccines can be also be administered as up in the age group of 12 and above. In India, mRNA vaccines for COVID-19 are still not approved by the FDA. In India, we have 4 vaccines which have been approved. One is the coronavirus recombinant Oxford, or what we call it as the AstraZeneca COVID-19 vaccine, which is a vector-borne vaccine. Secondly, we have an inactivated COVID vaccine developed by the ICMR and um, ICMR, and I don't remember the company. It is available by the name Covaxin. And the third one is Zycod-V. Probably Covaxin was developed by Bharat Biotech. The third vaccine is developed by Zydus Cadila, the Zycod-V vaccine. It has been now recommended in younger children of 12 to 15. And the fourth vaccine has just been recommended, again developed by Bharat Biotech. It is a nasal vaccine. The first 3 vaccines, that is the vector virus vaccine, the Zycod-V DNA vaccine, and the inactivated COVID vaccine, they are injectable, whereas the new one is the nasal vaccine. These were specific COVID vaccines, but other vaccines have shown to reduce the severity of the disease in patients. One of them was BCG vaccine, and this study was done during the COVID period. It found that there was a significant inverse correlation between the BCG index, or how well the BCG vaccine was deployed in a country, and deaths from COVID-19. It was found that every 10% increase in the BCG index was associated with a 10.4% reduction in COVID mortality. So more the BCG vaccine was administered, lesser were the COVID deaths. How it acted, no one knows. But this was the finding which was seen, and therefore, as compared to Northern America or as compared to the European Union, deaths in India were much lesser than those countries, because India has got a better better BCG coverage. A second trial was done using MMR vaccine. The hypothesis was, which was proved also, that higher level of mumps antibodies tended to have less severe disease or less severe COVID-19 disease. This occurred because the coronavirus acts in similar manner to the virus that causes mumps and measles. High mump titers from MMR2, that is the second dose of MMR vaccination, were found in subjects with asymptomatic and functionally immune cases. Subjects with moderate and severe cases of COVID-19 had low titers for mumps. Immunity produced by MMR vaccination boosters may provide some degree of protection against COVID-19 in adult population. Children, they are going to be safer. So MMR vaccine could be used, and this was also done in India, and it was found so that patients who had taken 2 doses of MMR had lesser severe disease, or had milder diseases. We spoke of this, how MMR vaccine hypothesis was. The MMR vaccine consists of weakened enveloped RNA virus, which is the same as that of COVID virus. The spike glycoprotein of SARS-CoV-2 plays a key role into the viral entry of the cells, which makes it an important target for developing new vaccines. Due to close similarities between the spike glycoprotein sequences of SARS-CoV-2 and viruses of MMR, MMR include induced in antibodies provide cross protection against COVID-19. This was the hypothesis and it proved to be true. Also, it was found that the methodology of entry of the measles vaccine, the measles virus, the mumps virus is similar to that of similar to that of corona virus, and therefore one can use those vaccines to add or to give additional protection. Flu vaccines. Flu vaccines do not prevent COVID, but flu vaccines, they reduce the burden of flu illness in hospitalized children and they reduce the deaths. The innate immune defense, which is stimulated by vaccination, consists of number of different elements that react to the infection in general, not specific to virus. The standing immune defense includes phagocytosis and dendritic cells and also various cytokines. The immune defense function independently of specific antibody which primarily targets the spike protein while fighting COVID-19 makes the virus coronavirus harmless. The cells that are primed with flu vaccine produce more virus fighting immune molecules such as cytokines than did those that are not being exposed to the vaccines. And therefore, flu vaccines reduce the course of the so-called cytokine storm, which can damage many organs in the child. So flu vaccine will reduce the chance of acquiring flu and other secondary complications in the children. And thus, because of multiple virus sensitization of the mucosa, it is going to fight against the coronavirus also. The pneumococcal vaccine and the Hib vaccine, that is Haemophilus influenzae vaccine, protect against bacterial pneumonias which might be secondary to the coronavirus infection. And therefore, use of these vaccines can reduce death in patient. For pneumococcal vaccine, we can use the PCV10 or PCV13 or PPSV23, as all of them, they offer adequate and similar immunity. This was about the vaccines. Now going for oral supplementation. We need to give supplements to all the patients, vitamin supplements to all the patients who are with corona, suffering from the COVID disease. A lot of emphasis has been given on vitamin C and vitamin D for development of immunity, but most of them, they have forgotten the use of vitamin A. Developing lung is especially sensitive to changes in the level of vitamin A. Keratinization of trachea and bronchi appear to occur very soon in deficiency. It is essential. Vitamin A is essential in the formation of lung alveoli. Vitamin A is an immune modulating agent and plays an important role in the immunological response to infections. It is involved in proliferation and maintenance of epithelial cells, including those of the respiratory tract, and also the binding or the intercellular binding of the cells. It is also responsible for differentiation and maturation of the cells of the lung. Nutritional vitamin A deficiency results in decreased alveolar septation and in marked changes in the respiratory epithelium. Available evidence showing that nutritional vitamin A deficiency induces negative histologic changes like necrotizing tracheobronchiolitis and altered immune function, which can make the patient land up into secondary infections or pneumonias or other lower respiratory tract diseases. So vitamin A should be provided considering that vitamin A deficiency is there. We have seen that along with the administration of measles vaccine, we give vitamin A. Similarly, measles virus has got a similar way of infection like that of coronavirus. Considering the same principle, we should administer vitamin A in a dose of 1 lakh to 2 lakh units to the patient once a month for 2 doses on day 1 and day 28, or day 1 and day 14. The second part is the respiratory epithelium is a ciliated columnar epithelium, and vitamin A deficiency causes squamous metaplasia of the respiratory epithelium, where the ciliated epithelial cells are replaced by squamous epithelium and provokes a decrease in mucus production, which is the primary defense mechanism of the respiratory system. Thus, because of the secreted mucoid secretions, alteration of the ciliated columnar epithelium to squamous epithelium, there always remains an increased risk of invasive pathogens. That those might be bacteria or those might be viruses also. The function of resident macrophages, neutrophil, and NK cells, that is the natural killer cells, and development of T-mediated antibodies responses are also impaired with vitamin A deficiency, leading to decreased protective mechanism at mucosal surfaces. So, though we administer vitamin C, though we administer vitamin D, we should not forget to administer vitamin A. Vitamin C could modulate function through modulation of redox sensitive cell signaling pathway or by directly protecting important cell structure components. Vitamin C deficiency may have an impact on the phagocytic activity and also the migration of these phagocytes to the site of infection. A supplementation of vitamin C enhances the function of neutrophils, including chemotaxis, that is chemical death of the bacteria or the virus. Thus, children benefit from improved immune cell function through enhanced vitamin C intake. Cytokines can elicit pro-inflammatory or anti-inflammatory response, and vitamin C appears to modulate systemic and leukocyte-derived cytokines in a complex manner. So, like vitamin A, vitamin C is also beneficial. Low vitamin D levels are associated with an increased risk of respiratory disease, including tuberculosis, asthma, COPDs, and BPDs. As well as it increases the risk of viral and bacterial respiratory infections. Vitamin D can influence all three innate immune factors. What are those? The airway immune factor, that is the epithelium itself, the columnar ciliated epithelium, the alveolar macrophages activity, and the dendritic cells activity. The airway epithelium forms the first line defense by preventing the entry of pathogen into the lung. The alveolar macrophages, they control the pathogens that have entered the alveoli by engulfing them, and dendritic cells by killing the pathogen by endocytosis. So vitamin D can influence all these three immune factors in the lungs and thus may play an important role in how the lung recognizes and responds to the pathogen. There is data to support both indirect and direct effects of vitamin D on adaptive immune response. Vitamin D increases antimicrobial actions of monocytes and macrophages, these which form the first line defense mechanism of a in an infection or in an inflammation. Vitamin D has been known to show reverse the steroid resistance. And vitamin D levels, lower 25 D levels, were independently associated with recent respiratory tract infections. So this was about the supplementation what we need to give to the child. So apart from vaccine, there are no vaccines still approved below the age of 12 years. We need to keep this in mind. Vaccines from 12 to 5 years, 12 to 15 years, they are the mRNA vaccine, the inactivated vaccine, and the inactivated viral vaccine, and the DNA vaccine. These are three vaccines which are approved by the FDA. A fourth vaccine has been approved, that is from the Serum Institute of India, named Corbevax. So these four vaccines can be used for children 12 to 15 years of age, 12 years and above, I would say 12 to 18 years. Anyways, we can use these vaccines. Apart from vaccines, we need to give them vitamin supplementations. Three vitamins should not be forgotten of: vitamin A, vitamin C, and vitamin D. Diet will form the most important part, because diet is responsible directly for development of, for as a source of proteins, as a source of antioxidants, as a source of ready energy, and therefore diet should be taken or considered throughout. One should advise children to eat various seasonal fruits, not stick to one fruit, but different kinds of fruits which are available, which are seasonal and which are available. One should eat legumes, nuts, and whole grains. That is, they should not be processed, like creating a multi use wheat flour, what we call it as maida, or what we call it as refined flour. One should not use it. Rather, one should use whole wheat flour. One should use maize, millets, oats, brown rice, or starchy tubers or roots. Starchy tubers like the sweet potato or the gourd. Uh, these things should be used. That is the yam. We should use all these things so as to get adequate antioxidants and adequate nutrients. Secondly, one should advise the child to stay hydrated. One should ensure adequate intake of fluids and electrolytes. Water is the best choice. No aerated or carbonated drinks, no high sugar drinks should be advised. Fresh fruit juices can be advised, but single fresh fruit, whole fresh fruit, is much more advisable. But if some child is not able to eat a whole fresh fruit, we can advise him to have a fresh fruit juice, not a stored or an preserved fruit juice. Prefer foods that contain healthy sources of unsaturated fats, such as fish and nuts. Limit saturated fats. Trim excess fat from meat and poultry. And if you are going to eat meat, choose the skinless option. Reduce foods such as red and fatty meats, butter, full fat dairy products, palm oil, coconut oil, or solid shortenings. So this was about the diet. So in short, prevention can be done by vaccines, by diet, and by supplementation of vitamin A, C, D. We spoke of the management which has been tried to be established, but it was not completely helpful. Contemporary management can be used, can be tried out. I personally have tried it out, and I have got good results from the use of contemporary management. For patients with COVID or MIS who are suffering from high grade fever, a decoction which has been described in Charak Samhita for the management of jwar, that is fever, one should use that decoction, that is known as Shadangodak. Shadangodak can be used in ample quantities like the ORS or like water, and it brings down the fever drastically and magically. It also helps in keeping the patient hydrated, increases the urine volume, and that is beneficial to every patient who has got fever or even COVID. This can be used not only in COVID but also in MIS, that is multisystem inflammatory syndrome. In cases with multisystem inflammatory syndrome, one can use a decoction made out of dashamul, roots of 10 plants which are known to be anti-inflammatory, and yashtimadu, that is Glycyrrhiza glabra, so as to reduce the inflammation of the systems and also that of the joints. Another Ayurvedic formulation, a decoction of Rasna Panchak or Rasna Saptak, which has been explained in a classical text of um, called as Yogratnakar or Bhav Prakash. Yogratnakar and Bhav Prakash can be used. These are 5 or 7 drugs which are used together, prepared a decoction and administered orally. Now one can see all these 3 decoctions, they are freshly prepared decoctions, they are not stored decoction, they are not processed decoctions, and therefore freshly prepared medicine would always be helpful. Secondly, these are all decoction, that is water based fluids, so certainly they are going to help you stay hydrated. Another 2 modes of treatment which can be used, that is anuloman, what we call it as a laxative or mild purgative, can be utilized in MIS, and use of enema therapy, that is the basti therapy, can be utilized in MIS, in multisystem inflammatory syndrome. So what would be the take home messages for COVID for the first lecture and this lecture also? Diagnosis of COVID in children is a difficult aspect. Suspicion is the key to diagnosis. If you suspect, you are going to diagnose it. If you do not suspect, you are going to miss out the diagnosis. SARS-CoV-2 infection is generally milder in children than in adults, and a substantial proportion of children with the disease have asymptomatic infection. Most children with SARS-CoV-2 infection will not require any therapy or any support. Some with comorbidities are likely to land up into severe disease and might require support or might require treatment. Children who have a history of medical complexity due to neurologic impairment, developmental delays, or genetic syndromes, including trisomy 21, obesity, chronic cardiopulmonary diseases, are or who are immunocompromised, are or older teenagers may be at risk of severe disease. There is a limited data on the pathogenesis and clinical spectrum of COVID-19 disease in children. There are no pediatric data from placebo-controlled randomized clinical trials and limited data from observational studies to inform the development of pediatric specific recommendations and protocol for treatment. So the protocols which have been drawn, they are all adult based. Children who have received BCG vaccine, 2 doses of MMR, and who receive an yearly flu shot are less likely to develop severe SARS-CoV-2 infection, and also if they develop a SARS-CoV-2 infection, they are less likely to develop related complications. So even if there is a outbreak of this pandemic, one should not delay these vaccines. Adequate provision of vitamin A, C, and D should be done as a vitamin supplementation to prevent complications of COVID. Advise the use of fresh diet, fresh fruit, seasonal fruit, and consume wholesome grains. And above all, rather this should be the first one, follow universal precaution rules. These are to be followed to prevent as an prevention or as a preventatory measure so that we do not contract the disease. It's prevention is always better than cure, and if we can prevent the infection, we always are at a beneficial side. Thank you very much.